Just for some introduction, my name is Michael Horowitz. Two of my partners and I are now have worked at UPMC for. I was there for. I trained there in residency, left for a couple of years, and came back in 1999. Been there from 1999 until this past November, running, and I was in charge of the vascular and the cranial nerve programs there. And I formerly was the chief of neurosurgery at the Presbyterian Hospital. My partner, Rich Spiro, who is not here today, his son is 11, is a ranked squash player, and he's driving him to a tournament in Dayton. And he'll come and give some talks another time on spine. He also trained at UPMC and has been there after residency for about 11 years, 12 years. And then our third partner is Pedro Aguilar, who also trained at UPMC and has been there in practice about five or 6 years. So we left UPMC in November to join the Highmark and to help them build out a neurosurgery institute. We have signed on to provide 24/7, 365 coverage for neurosurgery at Butler. We'll also be providing our practice will be at West Penn Hospital, Canonsburg, Jefferson, and Forbes. So we'll see a lot of you, and we're not here for the short term. We signed on to cover this hospital for 10 years. So we hope to build a pretty extensive practice and do things that are not currently being done here. So today I'm going to give 4 talks that I was asked to give, and some of them you may find a little elementary. And I apologize for that. We plan on coming back and giving additional talks in the future, which will get more and more in depth into specific topics. But I wanted to just cover the basics today. So the first talk is on the essentials of the neurosurgical neurologic assessment. And the reason I say the neurosurgical neurologic assessment is we're not aiming to do a neurologist's exam. That's not what you guys are aiming to do when you evaluate and take care of the patients, both in the intensive care unit, in the recovery room, and on the floors. What you're really looking to do, and what we're looking to do, is to make sure that our patients don't deviate from baseline, meaning get worse, because any worsening are things that we need to, as a team, intervene on very quickly. So I really can't stress the first thing enough, and it really is the guiding point to all the other slides afterwards. And if all you leave with today is this slide, that's all that's really important. The neurologic exam is the single most important component of pre- and post-operative neurosurgical care. And imaging is important, but the most important thing is, again, seeing whether or not something has changed. And why is that important? It's important because a patient's outcome, surgical outcome, is most closely correlated with how they are prior to operating on them. So the better they are before surgery or before any intervention that we do, the better their chances are that they're going to make a recovery to whatever level they were before they presented with their decline. So early intervention is of the utmost importance. So bottom line, everybody has common sense, and then most of the people that we're working with have common sense and have a lot of clinical experience. So the rule is, if you think you should call, you should call. There shouldn't be any second guessing, oh, I'm going to wake somebody up, or I'm going to bother them. Oh, they're going to sound cranky when I call them at 3 in the morning. Yeah, they're going to sound cranky when you call them at 3 in the morning. That's a given. Everybody's cranky when you call at 3 in the morning. But in the end, you'd rather hear about something that doesn't matter than not hear about something that does matter. And I think you always have to keep that in mind. If somebody's really pissed that you woke them up at night, then they shouldn't be that patient's doctor. So trust your gut and always listen to the family. If the family tells you that this patient is acting goofy or has changed or there's just something off, they're probably right, and you should assess them more closely and call. So what are the things that cause changes in the neurologic exam? Brain swelling, and these are not in any specific order, they're just in the order that I'm just typing them in. So brain swelling, you can have brain swelling from a a variety of causes, whether it's a stroke, ischemia to the brain for some other reason, hemorrhagic stroke, brain injury, just too much blood flow to the brain, which we can talk about later in certain conditions or after certain treatments. As we all know, the brain is stuck inside a hard case. It only has so much room that it can be compressed or it can expand. And if there's something in the brain that's growing, the brain starts, the tissue around it expands and finally gets held up by the surrounding skull, and the pressure goes up. And it's the brain swelling is causing two things. It's causing distortion of the nerves and the axons from those nerves. And as they get stretched, they don't function as well. And it's also causing increased intracranial pressure, which decreases, we'll get into later, the perfusion pressure of the brain unless we adjust the blood pressure. And less blood that goes to the brain, the more difficulty the brain has to function normally. What are some other causes of change in neurologic exam? Brain bleeding. You get brain bleeding for a number of reasons. It can be traumatic, it can be spontaneous, it can be because you're on certain medications. That's something that we're going to detect with a scan, but the first thing that's going to detect that there might be brain bleeding or anything going on is going to be a change in the patient's symptoms or signs. So headache or change in neurologic function, some part of the exam that we'll get into. Hydrocephalus. Again, there's just so much room in the brain. The skull has three contents. It has the brain, it has blood, meaning blood flowing through blood vessels and going through the arterial and the venous system, and it has the fluid in the ventricles. If any of those things increase, the brain volume increases because of a bleed into it or some type of swelling. If the blood volume increases, which we'll get into in what conditions that can happen, or if the spinal fluid increases, then the volume of the contents of the skull increases and the pressure goes up in the brain. We make about 0.35 cc's of CSF a minute. That's continuous all day long. Now we also reabsorb that fluid, but there are conditions where we either don't reabsorb the fluid properly, or in other words, the fluid is traveling through the system, so when it gets to the arachnoid villi, which reabsorb CSF in the brain, it doesn't get reabsorbed for many reasons, whether you bled into the brain from a subarachnoid hemorrhage, and that's the villi are all clogged up basically from the blood, so they can't absorb blood properly. They can't absorb the CSF properly. Somebody may have an infection, and the infectious agents cause a lot of protein to be released into the spinal fluid, and that clogs the arachnoid villi. There are any number of reasons, but you can have fluid buildup for a variety of reasons. Or the pathways that the spinal fluid flows through the ventricles, through the four ventricles, at some point that gets clogged up. And that's when you hear the terms communicating versus non-communicating hydrocephalus. Communicating hydrocephalus is when the fluid builds up because it's not being reabsorbed properly. Non-communicating hydrocephalus means it could be absorbed properly, but the fluid just can't flow properly through the system to get to the point where it can get reabsorbed. The type of hydrocephalus is unimportant. It's just, you've got to remember that somebody can have fluid build up in the brain because we keep producing it. We don't keep taking it out. It's like a sink overflowing, and that causes increased pressure in the brain and a neurologic change. Again, because you get decreased blood flow to the brain. Almost every reason for a neurologic exam change, almost everyone, not all of them, is because the common final pathway is decreased blood flow to the brain. Cerebral ischemia, that's obvious. Somebody has a stroke, a blood clot to the brain, they're going to have decreased blood flow to the brain. They can also get vasospasm. Patients that get treated for subarachnoid hemorrhage. I know you don't see that here. Hopefully you will be seeing that here. But the blood that gets released into the fluid-filled spaces of the brain when the aneurysm ruptures can cause hydrocephalus, generally by clogging the ability to reabsorb CSF. Hyperperfusion, that's what I was talking about before, where you can actually have too much blood going to the brain. And that can happen after a carotid endarterectomy. I know you do a lot of carotid endarterectomies here. But that the brain, and the part of the carotid system that normally regulates blood pressure and blood flow, hasn't been seeing normal blood pressure or blood flow in a long time because the area has been stenosed. You take the plaque out, you damage, in taking the plaque out, the nerves in the carotid receptors and the carotid bodies get disturbed, and all of a sudden you've also opened up, suddenly now there's a lot of blood flowing to the brain, whereas before the brain only had a little bit of blood flowing through it. That's why the person was symptomatic from the stenosis. Once you do that, the brain's like, whoa, what's going on here? It can't auto-regulate itself. It can't just clamp down and what it normally does, which is control the amount of blood flow to the brain on its own. It has to wake up and figure out how to do that again. Those people can get increased blood flow immediately after surgery, and they can present like somebody that's having a stroke. They can present with seizures, weakness, and that's something that you need to kind of differentiate. And the ways you differentiate that generally are with imaging studies, but it's just another thing to think about is maybe this is not somebody whose blood pressure I need to raise, but it's somebody whose blood pressure I actually need to bring their blood pressure down for a while because even a normal blood pressure is providing too much blood flow to the brain. Seizures, it's something that we very often forget about or don't think about. But the patient that is not waking up after surgery, or a patient that was fine and all of a sudden has a decline in their mental status, may be having a seizure. And you don't have to be having convulsions or having any movement abnormalities for a seizure. You can have subclinical status, which is patients that are just lying there, and they may have seizures coming from their brainstem, or they may have seizures coming from their cortex, but it doesn't manifest as a movement disorder. Or they may be paralyzed. Maybe this is a patient that you have paralyzed with agents in the ICU because they're ventilated, but you can't get an exam from them when you take the paralytics off. So it's something that we can frequently forget about. But if you forget about it for too long and don't rule it out, the person's been in status, the next thing you know, for an hour or two, and their brain is irreparably damaged. So you'll see EEGs being ordered more frequently than you're used to, looking for causes of changes in mental status. Hyponatremia, I know that's not something that you generally worry about in general surgery patients or other types of patients, but it's very important in the neurosurgical patient. And while a sodium of 135 to 145 is normal, in a regular patient, a sodium of 130 you normally wouldn't worry about in a general surgery patient or a cardiac patient. In a neurosurgery patient, a sodium of 130 starts to get worrisome. A sodium less than 130 is very worrisome because it can cause significant changes in their neurologic exam, their level of wakefulness. So you'll see us be very cognizant of keeping people's sodiums over 130. Fever. Patients with neurologic injury, any type of neurologic injury, are very, very susceptible to fever, not susceptible to fevers, but susceptible to the effects of fever on their sensorium and on their neurologic exam. And somebody that just goes to 38.5 can become very sleepy. If they have other baseline problems, they can become weak. They can induce seizures when it normally wouldn't. And so again, these are things that we generally want to get our patients on cooling blankets more frequently than you would in a normal ICU patient. Hypoglycemia, that's obvious in all patients, but it's something you need to think about in a patient who may just be getting IV fluids. We tend to not put glucose in our IV fluids for neurosurgical patients because hyperglycemia in an already injured brain has been associated with poorer outcome. So in a patient that's been NPO and is not getting tube feeds and is not getting glucose in their fluids, you can run into hypoglycemia unknowingly. Dehydration is obvious. Hospital psychosis, you see that in all of your patients, especially the elderly in an ICU. Drug withdrawal. We always think about alcohol withdrawal, which is next on the list, but we don't think about drug withdrawal, and it's not always illicit drugs. I've seen, one of the most vivid memories I have as a resident was this woman that came up from the south, very, very prim and proper lady, came up for surgery at Presby, and I was on call, and at about 3 in the morning I called because she was running down the halls naked and screaming and cursing, and this is not what you would expect from her. And we couldn't figure out what it was until we spoke to the family the next day, and they hadn't told us that she was on, Xanax and Valium at home, just to sort of keep herself on an even keel probably between martinis. And benzodiazepine withdrawal is very, very detrimental. And people very often won't tell you that they're on those medications. They're embarrassed, or they don't really consider it a medication. It's just something that they take to calm their nerves. So always think about that. And finally, anesthesia, the effects of anesthesia. Patients that have had previous neurologic compromise, especially, are patients that are very susceptible to the effects of anesthesia. And anesthesia can change their exam even after it wears off. So you'll have a patient that goes to sleep with a history of hemiparesis or pre-op, operate on them, they wake up, go up to the floor, now they're almost hemiplegic. And you run through everything because you can't say, oh, this is due to anesthesia. In the end, you don't find anything, they end up getting better, and it's a known fact that anesthesia will worsen somebody's neurologic exam, especially when they went in to the anesthetic with some neurologic compromise. I'm sure there are other things that I could add on that list, but I think this covers most of them. So these are things you need to run through your head. What things should you be concerned about when a patient's upstairs? The beauty of this is there's a lot of things you don't have to be concerned about. And that's why I said before, this is the neurosurgical assessment, neurologic assessment. We're not assessing a Parkinson's patient. We're assessing a patient for, do they need to go back to the OR? Do they need to be imaged? Is there anything that's happening in them that's going to kill them? So any new weakness compared to baseline, we need to hear about it. Any double vision, we need to hear about. Any pupillary changes, we need to hear about. So sluggish pupils, obviously dilated pupils, but probably the most important thing is irregular pupils. Before a patient goes on to dilated pupil, they're going to develop an irregular pupil, an oval pupil. One pupil reacting a little bit more differently and look a little different than the other. And quite frankly, that it may be nothing, and that's what it's very important to document what the person's pupils look like when they're normal. So when they come up, so that you can say, well, if this person came in with one pupil more dilated than the other, or with some irregular pupillary shapes. You can pass that on to the next team, and they know that that's their baseline. The important thing is what is a change from baseline. Any new facial asymmetry. Somebody that has a new process, a hematoma, swelling in their posterior fossa, the cerebellum, anything under the tentorium. Generally, they don't have to, but they often will present first with some facial weakness before they start getting progressively worse than that and become obtunded. It's not guaranteed that that's going to happen. They don't always present with a facial asymmetry. But if they didn't have facial asymmetry and now you see a new facial asymmetry, so they smile or close their eyes, one eye is weaker than the other, the face doesn't come up evenly when they smile or talk, that we need to know about that. Any new sensory changes compared to baseline, changes in speech, those are usually things that are obvious, but don't attribute it to, oh, they're just sleepy. Oh, I just gave them some morphine, I just gave them a drug. Yeah, it might be that they're sleepy, it might be that you gave them a drug, but it might not be. So those are things that we want to hear about. Eventually you're going to get the feel for the patient and say, this is their speech, this is what happens to them at 3 in the morning when I examine them for the last 3 days, and it won't be concerning. But if you notice a change in their speech, either comprehension or spoken speech, then that can be a warning sign. Obviously, any decline in level of consciousness. Once again, don't just attribute it to, oh, it's late at night. You wake them up, and if you wake them up vigorously, they should be able to respond to you. And when you first wake up from a deep sleep, you're kind of groggy, but 30 seconds later, somebody can be asking you appropriate questions, and you're answering in a clear voice appropriately. Any new or worsening headache, it's imperative that we get called. That's fairly obvious. And any headache that's not relieved by normal medications, I put in Tylenol there, but if you give somebody Darvocet or anything that's mild medication, they don't get relief, you need to get called. The worst thing you can do is have somebody with a worsening headache, and you just say, the Tylenol's not working, so I'll just give them some morphine and see if that helps. You don't want to do that unless somebody tells you to do it. And if somebody tells you to do that without examining the patient or sending them for a scan with a new or worsening headache, I would question them and say, are you sure you want to do that, or do you want me to get imaging first? The worst thing you can do is take somebody with some type of brain swelling and give them an opiate, which is going to depress their respiration and maybe push them over the edge, not only because it depresses their respiration physically by driving down their respiratory rate, but also by decreasing their respiration, they're going to decrease their ventilation, their CO2s, their PA CO2 is going to go up. That's going to lead to more brain swelling because it leads to dilatation of the arteries in the brain, and will just put you into a spiral of increased intracranial pressure. So you'll see it's very, very rare that we order on a cranial patient that had a cranial procedure that we order any morphine on those patients until we know that they're beyond the 24-hour window of surgery and at the highest risk, and that other causes or problems have been ruled out. Any new nausea, any new emesis, obviously is important because increased intracranial pressure can trigger nausea and emesis. What kind of examination frequency do we frequently ask for? Well, if somebody's on the floor, we ask for generally Q8 hours and maybe Q4 hours. Usually it's not more frequent than that. An ICU patient is generally every hour. A patient immediately post-op that goes to the PACU, usually it's a Q30-minute exam for 4 hours. That covers you for those 2 hours, and then they'll go to either a Q1 hour, Q4, or Q8, depending on where they're going to go to. I put in angio patients because I do a lot of endovascular work, and we'll be doing angios and endovascular work here. Generally do that Q30 minutes for 6 times, and then if they're going to go home, they're going to go home at that point. If they're going to stay in, then they'll change to one of the others. And the reason it's Q30 minutes is not so much that we're worried about their neurologic exam, but we want their groin checked. We want to make sure they're not developing a hematoma in their groin, and we want their pulses checked to make sure that they didn't lose the pulses in the leg that we put the catheter and sheath in. One thing I don't have up here is it's important on patients that have had angiograms that while we want to keep patients modest and they want to be modest, that we make sure that we have their groins exposed for at least the first hour, and just by pulling the sheet over, because somebody could exsanguinate when you walk away, and you wouldn't even, they'll drop their blood pressure and pass out, and if they're covered with a blanket, you won't know they're bleeding until it's dripping on the floor. So patients get transferred after those procedures and get put in a setting where they're being monitored. We ask that their groin, at least where the puncture site was, is exposed for at least the first hour, so that any big hematoma or any active bleeding can be picked up very quickly. I know many of you know this, but I want to go through the common exams that we're going to use in order to assess the patient. And quite simply, the Glasgow Coma Scale, while it's meant for trauma and it's meant for coma, is the best that we could use this for every patient, and you wouldn't miss, if you're vigilant about it, you would never miss a patient that should have been intervened upon. And it's got, the nice thing about the Glasgow Coma Scale, it's also coma score, is it's very easy to transmit this information to somebody else over the phone. And it's got the 3 parts: eye-opening, verbal, and motor. It's something that you probably already have on all of your charts. If not, we're going to make sure that it goes up with every patient and is there, and that at every exam, in addition to vitals, that a Glasgow Coma score is just charted. Obviously, in a normal patient on the floor, it's very easy. It's automatically going to be a 15. You're going to talk to them, and they're going to open their eyes. Their eyes are open spontaneously. You're going to, hey, where are you? You're going to quickly know that they're oriented, and they're going to obey a demand, telling them, hey, hold your arms up, do something else, and quickly you're like 15. It takes all of about 5 seconds to do that. Obviously, in a patient that's compromised, it'll take you, instead of 5 seconds, it'll take you 30 seconds to do it. But it's very important. I mean, I can tell you, I do a lot of medical legal work, and there are a lot of cases where the nurse has done a great job of charting that the patient's Glasgow Coma score is getting worse and worse and worse, but nobody gets called. But they've documented it, and now the hospital's really screwed, because the nurse did a great job of showing that the patient got worse, but didn't call anybody, or did call somebody and the person didn't come up to look at them. So we're going to ask that this be charted, and we and the people that work with us are going to respond to any change. Any loss of a point in the baseline Glasgow Coma score is going to be important. So I don't care if somebody is an 8 and they stay an 8, which is a severe head injury, then that's fine. But if somebody goes from an 8 to a 7, that's concerning. If somebody goes from a 15 to a 14, that's huge. You know, anybody in here, if I told you that 2 seconds ago they were spontaneously eye-open, oriented, and obeyed, and then I told you, you know what? I just went and got coffee. I came back and I asked them for a pen, and they didn't know what I was asking them. You'd be concerned, and that's only going from a 15 to a 14. So those changes are big. So any loss of a point is important and needs to be communicated. The other way we evaluate patients, again, very easily, is the motor exam. So this obviously is going to be applicable for all neuro patients, but how about, for a spine patient that comes up and had a disc done, or had a cervical disc done, or a lumbar disc, or stenosis, or had screws put in? You want to assess them early on. A lot of these patients came in because they were weak. That's why they had surgery. So they may present as a 4. So they may present as a 4. That's fine. But you want to know if they go from a 4 to a 3. You want to know if they go from a 5 to a 4. And again, these are gross measurements that are easy to do, but a loss of a point is very, very important. Okay? So a 5 is able to overcome strong resistance. So whatever muscle group you're working on, you should have a little trouble overcoming it. We basically usually test major motor groups, so biceps, triceps, quadriceps, plantar function, ankle extension, abduction, adduction, and quite frankly, everybody in here, if you ask them to hold that position and they were normal at baseline, you'd have to push fairly hard to budge their joint. 5 means that they can still give resistance, but it's not what it was. It's not normal strength, or it isn't what it was. Supports limb against gravity. So this is somebody that can lift their leg up against, let's say you're examining their leg. They can lift their leg up or bend or straighten out their knee against gravity, but if you put your hand on it, they can't push up against your hand. 2 is moves, but not against gravity. So let's say you took this person and put them on their side and asked them to move their knee full range of motion. Well, they would. They'd be able to move it from side. They'd be able to do it at that point because gravity's not pulling on it. But if you then put them on their back and ask them to do it, they can't resist the pull of gravity. 1 is just a flicker of movement. You can see some movement there, but it's barely moving at all. And 0 it's plegic. So again, very gross, 0 through 5, a loss of, just like the Glasgow Coma score, a loss in 1 point is significant. NIH Stroke Scale. This will be for patients that we treat with stroke. I think that endovascularly, the first thing that we'll see here in terms of patients that are going to the ICU are going to be stroke patients, because these are not elective patients. These are patients that are going to be brought in by EMS and will not be transferred out, because the time to transfer out, we might as well treat. This is not something that's being done here right now, except for IV therapy, but later on we'll talk about IA therapy for stroke. Intraarterial, meaning or intravenous. And again, it's a scale, it's 0 through 42. 0 is, in this case, 0 is normal. 42 is basically you've been annihilated by the stroke. And this is how the scale breaks down in terms of how neurologists think about it and the ranges, what's no symptoms versus severe stroke. I know you guys have these forms here, and I know you've gone over them, and I saw there was a talk on that computer there, so it's obviously been given before. Our group is hiring, I do endovascular stroke and have trained a lot of stroke neurologists to do endovascular, to treat strokes with catheters, and our group will be hiring a stroke neurologist that also does endovascular, and that will be between them and myself. And the stroke neurologists here are going to be the people that you'll be interacting on the stroke end. But I just wanted to show that there are 3 basic scales that we're going to use to evaluate our patients. So it's very simple. It's going to be the Glasgow Coma score, it's going to be the motor exam, and it's going to be the NIH Stroke Scale. Any questions before I'm going to keep going, but any, like, you can't hear me, or I got something in my teeth? When I was a resident, this is what I was taught, and this is absolutely true. If there's only one exam that you can do a patient, the quickest exam, it's good, and the most reliable and the most telling, is Pronator Drift. Okay, and I think everybody here knows how to do the Pronator Drift. Ask the patient to put their arms out in front of them, if they're lying in a bed or sitting up, whatever. Ask them to put their palms up, close their eyes, and hold their arms there. Okay? Everybody should be able to hold, if you're normal, your arms should stay rock solid. You and you want to tell them, I want you to keep your hands flat like you're holding a pizza box. Why is that important? Well, because if you ask a patient to do it, it means that if they test their level of alertness, because they got to be conscious enough to follow your command and do it. Again, it assesses their ability to follow commands. It assesses their strength, and it's very, very sensitive to any small changes in power. So if you ask somebody to hold their arms out like this, somebody that has some weakness, one of the first things you're going to see is that you ask them to sort of forcibly evert their hands like they're holding a pizza box. The side that's weak is going to start rolling in like this. Okay? It's the other thing you're going to see is when it's weak, you're going to tell them to hold their fingers together like this. If they're weak, you're going to see their pinky start to go out a little bit. So those are two very subtle signs that there's weakness. Now, that may be their baseline, and that's fine. But if they came up and they were doing this, and then 2 hours later they're doing this, that's abnormal. They shouldn't be like that. And you want to call and say, look, I'm noticing that they are starting to turn their hand in when I ask them to do Pronator Drift. And then we'll say, well, check all these things on the list. Is their sodium okay? Yeah, it's fine. Blah, 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 blah. Okay, call me if it starts getting a little worse. We'll get a CAT scan. But at least you're on alert that this may be a problematic patient. This happens at the end of your shift. You tell the next nurse, look, I noticed that it was normal. Now it's doing this. Please be careful. If it gets any worse than this, we need to be on it. It assesses cerebellar function. Okay, your cerebellum has to be functioning normally in order for you to be not having ataxia, and not have your arms moving like this. This takes coordination, especially you doing this with their eyes closed. You're not doing it with their eyes open. So when they close their eyes, somebody that has a cerebellar dysfunction, they don't know where they are in space, and they can't use their vision to keep their arms there, because now they're just using their cerebellum to judge where their arms are in space. And it also assesses parietal lobe function. So it assesses frontal lobe function with level of alertness and following commands. It assesses general strength, which is the frontal lobes bilaterally. It assesses their cerebellar function, and it assesses their parietal lobe function. The parietal lobe is responsible for where is my body in space. And somebody with a parietal lobe function, whereas somebody who has weakness, okay, may drop a hand like this. Okay, this hand's the weak one. They can't hold it up. Somebody with parietal lobe function, their hand will go up. Okay, so it literally is the single most exam. And I'll tell everybody here, if you leave with one thing on how to examine a neurological patient, a neurosurgical neurologic patient, and there's only one thing you're going to do, or the first thing you're going to do, this is the most important thing. And we ask this is to be done on every single neurosurgical patient at every single exam, and it needs to be documented. So one of the closing thoughts, obviously, I didn't spend an hour, we can take questions, is the neurologic exam is the single most important item to perform and document before and after surgery, and I can't stress that enough. It costs nothing except your time, and we're all being paid for our time anyway. And it is more sensitive than anything else. A CT scan, somebody having a stroke, you can bring them down for a CT scan when they're having a stroke, and the CT scan will show nothing, because the findings on a CT scan for ischemic brain are delayed. It takes 5 or 6 hours to see changes on a CT scan. Somebody's having a stroke, you're going to see a change in their Pronator Drift immediately. So it is the most sensitive, the least expensive, and the most valuable thing you can do. It's the most important thing to do and it's to document in the non-surgical patient under observation, and it needs to be done before their intervention and after their intervention. So it's very important to know how did they go into surgery, so you know what's abnormal after surgery. Somebody comes in with a paralyzed leg after surgery, well, it's concerning if it's new, but it's not concerning if it was paralyzed pre-surgery. Somebody had 4/5 strength in their leg pre-surgery, post-surgery it's 3/5. It's concerning, but you know, if it's in the first hour or so, it may very well be due to anesthesia. So it's still moving. It's not overly concerning at this point. So you say, well, let's wait an hour. We'll wait for the anesthesia to wear off. It gets worse over that hour. That's concerning. If it doesn't change over that hour, after that hour, that's concerning. If it gets better, you chalk it up to, oh, it's because they went in with a deficit, had anesthesia, now they just have to recover a little bit. As I said at the beginning, if you think there's a problem, there is a problem, until proven otherwise. So, assume the worst. All the other minor things that are less important in terms of reversible things, like Mrs. Smith, who's 75, is being really inappropriate at 9 o'clock at night. That's because she's in the ICU. Well, yeah, maybe because she's in the ICU, but that's a diagnosis of exclusion. Okay? All the really bad things need to be quickly ruled out first. And I don't mean going down for a CT scan every time somebody passes wind, but we need to really look at the patient and say, you know, is there something else going on? Either she's acting odd, does she have a headache? Does she also have a new pronator drift that goes along with it? Can we put some other things together that you wouldn't see in somebody that's just having ICU psychosis? If she's having ICU psychosis and she's beating the crap out of you, okay, she's not very weak. Okay, she's just very, very confused. So maybe it's medications that she's on. Then obviously you look to adjust the medications first and look at her medication list before you just say, oh, it's ICU psychosis. So the minor things are fine. The minor things are the most common things. But at least for a neurosurgical patient, and it's the same thing for a cardiac patient, they're having chest pain. You know, your first concern is it's ischemic. You might quickly rule out that it's GI by giving them some an antacid or something, but you know, you're not just going to sit on it for 3 hours. So always assume the worst, and we'll hope that it's not that. Never be afraid to call about a neurologic change or a suspected change. And yes, people are going to be grumpy at certain times. Yes, people are going to be busy. They may be operating. They may have 50 patients in clinic. You know, they may have just had a fight with their wife or their girlfriend, whatever. And people are going to be moody. But the bottom line is you called and you held up your end. And I think everybody that's in this business has pretty thick skin. And the bottom line is patients die when the neurologic examination is ignored. Patients die, nurses and doctors get sued, and hospitals get sued. If you have done the exam and called and done the appropriate workup, if the patient has a poor outcome, and you've done everything you can to try to avoid that, then that's, you know, an act of God. But we don't want to miss stuff that we can treat or reverse. So that's my spiel on neurologic evaluation for a neurosurgical patient. Do you have any questions? Questions because everybody's sleeping, or just no questions?
You're in the vasculars. Will you be doing those in the cath lab?
Yes, I'm in the cath lab. And I'm going to talk about, when we do the craniotomy talk, I'm also going to talk about endovascular. I'm going to have 2 YouTube videos showing you 2 procedures. They'll play for both of them. They're narrated. They'll play for about 20 minutes, but they'll give you a flavor of the kind of stuff that we're going to be doing down there.
Do you always do a femoral approach?
I would do a femoral approach unless we can't access them femorally, and then we'll go either radially or brachially, or very, very rarely a direct carotid stick, but it's almost 99% femoral. Yes, ma'am?
So the situation where the patient needs Louisiana, where we call and they need to be seen by somebody, how far away, or like if it's in the evening or into the night, would somebody either come?
Yeah, well, we've met with the ER, we've met with the intensivists here, the hospitalists, I mean, and our patients will be covered by, obviously the ER is the ER. Our inpatients will be covered for, for emergent issues like this by the hospitalists or the intensivists, depending on where they are, and they'll be seen and evaluated. We live each of us live about 40 minutes away when there's no traffic, and so we're available to come up, but there'll be somebody will come up and evaluate them. So it won't be, if you call us and say, look, somebody's dilating up a pupil, somebody's going to come up and see them. And if we say, look, they need to be intubated and taken down for a CAT scan, by the time those things are done, or they need to be taken down for a CAT scan, we'll be here. If they need to go to the OR, we don't need to be here. We've spoken to the OR for OR emergencies. They will take them directly to the OR without us being here to talk to the family face-to-face and obtain consent. They'll bring them to the OR waiting for us to come up here so we don't waste time. Strokes, the same thing. We'll work on getting patients to the cath lab while we come up. And I can tell you in somebody that's not intubated, that needs to go back to the OR, needs to go to the cath lab or something like that, it takes a half hour just to get them from point A to point B, another 10 minutes to get them draped and stuff, and we can be up there by then. So it shouldn't be an issue.